Hello, good morning everybody. On behalf of my co-chair Francisco Calvo and myself, welcome to this morning session on basic topics and physiology. We have this morning two outstanding lectures that's going to give us the new insights into two very interesting topics in basic research and physiology. Because it's not my time to talk, but their time to talk, I'm going to give Bernard Gesch the opportunity to tell us his personal thoughts and opinions about cell therapy after myocardial infarction. Tell me the truth. Bernard, whenever you're ready.
Do is provide you with what I think is a clinical perspective of a complicated field. Now, the theory behind cell therapy in acute myocardial infarction is this, that with acute myocardial infarction, you develop infarct expansion, adverse LV remodeling, chronic LV dilatation, and chronic heart failure. And this is the classic diagram drawn by Dr. Mark Pfeffer almost 30 years ago. The plan and the target and the goal of cell therapy is to interfere with this process by using cells that will reduce vascularization, and at least that will oppose the reduction in vascularization and apoptosis. So stem cells are thought to act by regeneration or by paracrine factors, and either of these can have an opposing effect on the deleterious effects of reduced vascularization and apoptosis. Now, if one looks at the early work on stem cells in the first 10 years or so, what was striking is that everything works, irrespective in the animal model and the early clinical studies, irrespective of whether the cells were allogeneic or autologous, extracardiac or intracardiac, everything works. Irrespective of the number of cells, the site of delivery, the method of delivery, and it has been estimated by Dr. Murray that if you look at all the studies, the range, the dose of cells varied by 6,700-fold. Never seen anything like it. Never seen anything like it. It would be like one antibiotic that takes care of every problem, whether it be viral or whatever. Irrespective of what was done, all of these studies showed an improvement in ejection fraction, a reduction in infarct size, improved diastolic function, reduced volumes, and in some of the studies, improved perfusion. In these early clinical and experimental studies, the cells were effective both early and late post-infarction. And what was quite extraordinary is in this study from Dr. Zhao's laboratory, the benefits were noted within 72 hours, and with just giving the conditioned medium alone that the cells were grown in, without giving the cells, they then saw the benefits again within 72 hours. Now, if stem cells work by regenerating cardiac muscle, they will never do it in 72 hours. So this is an extraordinary situation that I think we were faced with about 7 or 8 years ago. If you're not confused by this, it's too early in the morning for you, because it's very confusing. And if you're not confused by this, you're not thinking clearly, because no one has ever seen anything quite like this. And so the explanations and the proposed mechanisms of benefit are this. The original theory was that cells, whether they be embryonic stem cells that go down the line to bone marrow stem cells and differentiate into mesenchymal cells, that these cells would in fact grow new myocytes. The other theory, the so-called paracrine theory, is that these bone marrow cells, in fact, are angiogenic, and they may stimulate resident endothelial progenitor cells that go on and create new blood vessels. And the other theory is that other paracrine factors, all of these are paracrine factors, may act to immunomodulate, cardioprotect, and in fact protect the myocardium. And one of the most interesting aspects now is that perhaps these bone marrow stem cells have a cardiogenic stimulus and that they stimulate resident cardiac stem cells and have a healthy myocardium. So these two mechanisms could lead to cell regeneration, but these mechanisms, which are paracrine, could have benefits independent of cell regeneration. And the fact is that at the moment, I think the prevailing hypothesis of why all these experiments have been successful is because there are paracrine factors being released. What have we learned from the early clinical studies? It's safe and feasible. Studies predominantly in bone marrow stem cells, mononuclears, and hemopoietic cells. With skeletal myoblasts, we get ventricular arrhythmias, and skeletal myoblasts will never stand the test of time. If you look again at the phase 1 clinical studies, the last 10 years, a modest improvement in LV function, ejection fraction increase 3%, improved perfusion remodeling and coronary flow reserve after MI in some of the studies. Clinical outcomes, none of the trials were powered for clinical endpoints. They were all underpowered. They're small trials, but the clinical outcomes, the trends are favorable. Now, the downside, the majority of implanted cells disappear within 1 week. There is no evidence at all of myocyte regeneration using existing therapies. And this, again, leads to the paracrine hypothesis as an explanation for the beneficial effects. And one other explanation is that perhaps these cells stimulate endogenous cardiac progenitors, so that the bone marrow cells that disappear within a week may stimulate the development and production of endogenous cardiac progenitors. Recent trials have had mixed results. Some are positive, some are negative or neutral. I think they generate new questions, and they also reflect an incomplete understanding of the basic mechanisms of benefit. And what we need are new cells and new strategies to improve survival and proliferation under evaluation, and these are under evaluation. What will also happen is if we develop cells and techniques that prevent the cells from disappearing within a week, we will need to revisit the safety and feasibility, because the comment has been made, and it's not unreasonable, that the safety, all the studies have shown safety, but that may be because the cells disappear within a week, and that may have to be revisited in the future. So I think we've realized that it's much more complex. There are many barriers to myocardial regeneration. We may not have the right cells, but we've also realized that the environment surrounding a myocardial infarction is very hostile. And it's a very inhibitory environment. There's inflammation and apoptosis that acts against the cells. And then there are a number of tissue factors, the lack of cell contact and integration, and rapid washout of injected cells. So there are many barriers to myocardial regeneration. It is not as simple as it looked in the laboratory 10 to 15 years ago. And I think that stem cells have gone through what I call the natural history of evolving therapies. You start off with progress, and then there's a period of great excitement, almost euphoria, a reality check, then usually a period of depression, and then you put things into perspective. In fact, we went through this with drug-eluting stents. The firestorm at the ESC 6, 7, 8 years ago, where everybody suddenly became aware of early stent thrombosis. And I think what has happened with stem cells is this: the initial enthusiasm has been tempered, and the number of unanswered questions is not decreasing, it's actually increasing. Nonetheless, the field maintains its promise. But I think we have gone through a period of reality check and placed it into perspective. So what about the new generation of cells? This is from a review my colleague Atta Befar, Andre Terzik, and myself have just published in the last month in Nature. First generation stem cells, the cells we've used over the last 10 years, from the bone marrow iliac crest, bone marrow mononuclear cells, which evolve into endothelial progenitors and can evolve into mesenchymal stem cells, or include mesenchymal stem cells. I shouldn't use the word evolve. I should say that amongst these bone marrow cells, there are endothelial progenitors and mesenchymal cells. The next generation, the one we're in now, focuses on two groups of cells. Resident cardiac stem cells, which break down into two kinds, isolated cardiac stem cells and the so-called cardiosphere cardiac stem cells. This is the work being done by Roberta Bowley in Kentucky, and these are the cells being worked on by Dr. Eduardo Marban at Cedars-Sinai, and I'll come back to the trials. So a great deal of interest in cardiac stem cells, because the one beauty of the cardiac stem cells are that they come from the heart, so they are electrically integrated. What we've been doing at Mayo Clinic in Dr. Terzik's laboratory is to take bone marrow stem cells, isolate them, and then treat them with what he calls a cardiopoietic growth factor cocktail, and this induces lineage specification. And what do I mean by that? It means that this drives these cells to become cardiopoietic and not tumor cells, or cells that are going to settle in the liver and become hepatocytes. Because these mesenchymal stem cells, or primitive cells, can go in many different directions, just like embryonic cells. So what he does is the principle of guided growth, and that is to take the cells and guide them down a specific lineage to become cardiopoietic. Other approaches are shown here, and this is to see if we can facilitate the survival of implanted cells by modifying them in a different, using a number of different agents. And this is a study that was very interesting for me because I worked with people in Beijing, Lei Song and his group in China. And what we did was, in the animal model, control mesenchymal stem cells and then gave atorvastatin that stimulates nitric oxide synthase, and then we inhibited it with L-NNA, L-arginine NNA. And what you can see is that with stimulation, if you look at the red, there's an increase in mesenchymal stem cells. And if you look at it displayed graphically, control mesenchymal stem cells treated with atorvastatin and then inhibited by L-NNA, and I think the results are quite striking. So this is one of many approaches. The other approach is to genetically modify stem cells so that they remain in the tissues for a longer period of time. This is the 5-year follow-up from Andreas Zayer's repair trial, long-term clinical outcome, just published in the European Heart Journal in the last week or two. And what was really interesting here is to look at the event-free survival in those cells that were healthy versus those that were not. And health was defined here by the ability of the cells to migrate when stimulated by stromal-derived growth factor. So when we take cells from the bone marrow, we are taking cells from sick patients and older patients and giving them the cells back. Some of those cells function normally and some don't, and this is quite striking and suggests that those cells that were more mobile and more functional performed a lot better in the long term than those that did not. So we have the second generation cells and we have modified cells. What about the recent trials? The previous slide I showed you, I called that phase 1. That was the first 10 years. But now we're in phase 2, the next 5 years, or the last 5 years. 4 trials done by the NIH, very well conducted trials of autologous bone marrow cells, late time, focus, and then the Swiss AMI trial. These 3 trials from the NIH under Bob Samari, who you've met before, many of you, who's a colleague at the Mayo Clinic. What were the results? Neutral for primary endpoints. There have been some interesting subset analyses, but the fact remains these are neutral trials. The primary endpoints were LV function and infarct size, no difference. But there are some subsets that have shown that the healthier cells appear to do better than the cells that are less healthy. What is the future of bone marrow stem cells? I'm not sure. There's one trial now, the European Union trial, the BAMI trial, that should answer this with 3,000 patients. Personally, I think this trial is underfunded. It's too small. But that's the best we have. What about the recent trials of second-generation cells? Adipose tissue-derived cells, one of these studies carried out by Paco Vilas in Spain, and many of you collaborated. The attraction of adipose-derived cells is there's lots of it. There's no shortage of supply of adipose tissue. So it's very attractive, but the trials, neutral. And then mesenchymal cells. There have been a whole series of trials, and if you look at the results of these, it's difficult. This trial by Josh Hare, no control group. This trial has not yet been published. This trial has no placebo group. This is the largest trial presented at the American College of ACC meetings last month. And this trial of mesenchymal cells and heart failure, 59 patients from Copenhagen, a 5% increase in ejection fraction, and functional status was improved, both in treated patients and in controls. Number of patients, 69. So I think 5% ejection fraction is probably an improvement in what we've seen before, but small trials. And what about the trials of the cardiac and the guided stem cells? 2 trials of cardiac stem cells, Caduceus from Dr. Marban and Scipio from Dr. Bowley. 25 to 33 patients in each, and the results are complex. If you actually look at LV function in the trial by Marban's group, no change in LV function. In the Scipio trial, a remarkable 8 to 12% increase in ejection fraction. And that's not relative increase, that's an absolute ejection fraction units. The Caduceus trial also uses an MRI endpoint, and the interpretation is that there is an increase in viable mass, that they have seen regeneration. The alternative explanation, actually, is that this could be hypertrophy, and the reduction in late gadolinium enhancement, which reflects the reduction in scar, could be due to less vascular permeability. And what I'm saying is the endpoints of these trials are complex. It depends on how you interpret the MRI, but at least provisionally a large change in ejection fraction in this trial and an improvement in probable viable mass in that trial. But the numbers are small, 25 and 33. Now, the guided mesenchymal stem cell trial by Dr. Terzic and Dr. William Wines from Terzic from our group, 48 patients, ischemic cardiomyopathy, fully revascularized. And I might add, in the Scipio trial, what also complicates it is that these patients had bypass surgery. And here you see an increase in mass of ejection fraction of 7 units, which is quite significant, and an increase in 6-minute walks. So some promise in this trial and some promise in these trials. Very difficult to work out in this trial who got in and who doesn't get in, which is the placebo group. It's very difficult to analyze, but some promise with a new generation of stem cells. 2 other trials that are promising. This is a trial of patients from Dr. Lasordo who had CD34, that's enriched bone marrow cells, CD34 positive cell therapy for refractory angina. 167 patients, double-blind. And if you look at the number of weekly angina incidents and the change in ejection time, there is a significant difference, 0.035 and 0.017 between controls and the various doses of autologous CD34 cells. So it's actually 167 patients, and it's a positive trial. And although not powered for clinical endpoints, you can see there's a 12-month reduction in mortality. But I emphasize again, the trials were not powered for that. But it's a promising trial, and he then followed up with another trial of enriched bone marrow cells, CD34 plus, 28 patients with severe peripheral vascular disease, and this is the difference in amputations. High dose stem cells, low dose and control, and if you look at major amputations, high dose, low dose and control. So, amputation's a pretty hard endpoint. And the feeling was that because we, at least at this point in time, have not shown muscle mass regeneration. We've not shown that. We feel the paracrine factors are the most important mechanisms. It may well be that these cells are angiogenic through the paracrine substances that they release. So a lot of interest in bone marrow or stem cell therapy for refractory angina and angiogenesis. And unfortunately, the major trial has been stopped, not for efficacy, and not for lack of efficacy. It's been stopped because of financial reasons, and maybe we can discuss that later. So how do I summarize things currently? Basic and translational science is resulting in rapid scientific progress on many fronts. There is a huge worldwide effort going on. But it's a very critical time for this entire field because, the clinical trial results of the second generation cells that I've just shown you, there's a question mark. Is the magnitude of difference in these trials with second generation cells significant? Is 5%, 7% better than the 3% we saw before? And believe me, if you can understand the Scipio trial, you're better than I am. It's very complex to understand quite what's going on. We've got at least 5 ongoing phase 3 trials. We won't have the results for about 5 years. Is there a future for bone marrow stem cells? The future rests upon the European Union trial BAMI, the RENEW trial, which was a trial by Lasordo of CD34 plus cells, as I mentioned to you, was terminated in December. I was on the Data Safety Monitoring Board. I am allowed to say that it was not terminated for safety or efficacy reasons. It was terminated because of a decision by Baxter that they were not going to pursue the field anymore. Great pity. Very important trial for us at a critical time. Really important trial, but it's gone now. So what do we know? Stem cells are not ready for clinical application outside a research trial setting. What we know is the tip of the iceberg. Many questions. Which patients? When should we give the drug? Which cells and what numbers? And this is a very important phenomenon. We take sick patients. We then draw their bone marrow cells and we give them back to those patients. And what we have learned in the last 5 years is the older and the sicker the patient, the less active are the cells. And so one approach, which is rather exciting actually, is to take the cells and rejuvenate them by a variety of techniques, some of which I've shown you, and then heal the cells and then give them back to the patient. Because as I also showed you in the 5-year data from the repair trial, the healthier cells that have greater migratory capacity do well and do better. Cell isolation and storage procedures. Many strategies going on to try and augment cell homing, retention, dedifferentiation, and engraftment. And these are not just approaches aimed at the cell. These are approaches at modifying the environment to attract the cell. Safety and clinical impact. And safety is still paramount. This is a very disturbing report from Russia of a young man who had ataxia telangiectasia and underwent multiple intrathecal stem cell transplants in Russia. Subsequently, that was in 2001. Subsequently, he emigrated to Israel, and a diagnosis of glioneuronal tumors was made in the brain and the spinal cord. This is dangerous stuff when you use primitive cells. And remember, primitive cells can go in many different directions. And so last year, this article in International Herald Tribune, the International Society for Stem Cell Research released a statement declaring the use of stem cells outside scientific settings to be a threat to patient welfare, patient autonomy, and the scientific process. The only rationale for giving cells outside the field of hemopoiesis, which has been around for a long time, but the only rationale for giving these cells is as part of a clinical trial. So it's a time for perhaps cautious optimism. Will it flourish? Will it founder? It's a question mark. I think the enthusiasm and the allure and the excitement has moved ahead of the science. It's now 14 years since the first trial of angiogenesis and gene therapy was carried out. They've all been neutral. You can't even get funding for it anymore. There is, though, rapid progress in clinical and translational science. I think that collaboration with the basic and the clinical scientists is essential for the design of future trials that are very focused. And what we've also learned, and we learned this with simplicity a month ago, and we've learned this in the stem cell field, the importance of controlled experiments and blinding. As President Bush said, if we don't succeed, we run the risk of failure. And you know, there's a point to be made here. Funding sources lose patience when they get negative trials. They want positive trials. And we need positive trials in this field. Otherwise, we will fail, and we'll fail prematurely. So as I look at the future directions, I just throw this out hypothetically, really. Which cells for which disease? What we have to think about is cardiac disease is not just a single disease. We have ischemic cardiomyopathy, we have non-ischemic cardiomyopathy, and we have refractory angina. For ischemic tissue, if this is ischemic LV dysfunction or peripheral vascular disease, perhaps the cells that will work are the enriched bone marrow cells that have angiogenic potential, CD34+, CD133+. This was the RENEW trial, terminated on the 6th of December. When you look at cells where the predominant pathology is scar or necrotic tissue, perhaps these angiogenic cells will be of no value at all. Now we want cells that regenerate, and perhaps mesenchymal cells or guided mesenchymal cells, as Terzic does. There's a very large trial now called TIVA, 1,700 patients of mesenchymal precursor cells, and perhaps the resident cardiac stem cells. So perhaps these trials, these cells will work for this problem, but if the primary problem is ischemic, we may need different cells. And then we come to idiopathic dilated cardiomyopathy. Now, this is a condition that is not characterized by scar tissue. Idiopathic dilated cardiomyopathy is characterized by dysfunctioning cells, and I have no idea how you should approach that, but I am concerned about the trials that lump these three pathologies together and say, let's give some bone marrow stem cells and see what happens. So future directions. A pivotal trial demonstrating significant benefits on LV function, like an ejection fraction change of 10%, will change clinical practice. I don't know how many of you are aware of the change in ejection fraction with the first trial of thrombolysis, the GC1 trial, 2%. Changed clinical practice. ACE inhibitors, 3%. So it will, if we could get that trial. Resident cardiac stem cells and guided mesenchymal stem cells are the most promising cells at the moment. We need larger phase 2 trials to assess the relative benefits of these compared to bone marrow stem cells and their progenitors. And I think it is clear that it's not just the cells. We will need enhancement strategies, both to change the environment in which we place these cells and to modify these cells in addition to the environment. And we're going to need that to improve current results. It's not just going to be the cells alone. So I close with this review that wrote with Atta Befar, Current Status of Stem Cell Therapy, a Clinical Perspective. And we said, stem cells, clinical trial results, is at the end of the beginning, to quote Churchill, or the beginning of the end. And I think it's the end of the beginning, but I think it's a very critical time for stem cell therapy, and the next 5 years, I think, are really going to determine whether these cells have a place in the future. Thank you for your attention.
Thank you, Bernard, for an excellent overview. I wonder if there are questions from the audience. And while they think about the question, let me, you talked about so many things that there are many questions that raise to me. For instance, would you promote autologous versus allogeneic stem cells? If we're going to go to the cardiopoiesis of Andre Terzic, probably autologous is a good way to go. If we're going to do resident cardiac stem cells, autologous may not be so interesting. Is the future going to bring us a bank of cells in the cath labs that we're going to choose from? Which is your vision from that?
I think so. I think so. That is, from a visionary perspective, I think it's our approaches have been very simplistic, understandably so. You know, we start off with bone marrow stem cells and that's it. I think we may have a bank of cells, and some of them may be autologous and some of them may be allogeneic, and I think it'll depend on the underlying pathology, but I tell you, we're a long way off from that. I mean, one of the advantages of bone marrow stem cells may be that they're not pure. Most of them are just lymphocytes. They're not worth anything. But within those mixture of bone marrow cells may be the different cells that we talk about. So it's not, although bone marrow cells are not pure, it may be that they include enough of the clinically relevant cells that could be effective. But I think, from a visionary perspective, I do think of a bank of cells that will be tailored to the particular condition we're treating. Now, many of us who work in this field really felt that we would, within 5 years, we would get clinical approval for stem cell therapy for refractory angina and maybe peripheral vascular disease with claudication. We really had, I was very encouraged because the Losordo trial was positive, but there was another trial from Holland in refractory angina that was also positive, about 200 patients. And then the claudication trial, but right now, that trial is on hold and I don't know. So I think that those cells would be very different from the cells we'd give people with, where the primary problem is scar tissue and LV dysfunction.
And let me ask you, from your expertise in clinical trial designs, so the endpoints would ultimately always be clinical benefit and clinical survival and clinical improvement. But I really liked the neatness of Marwan's trial, the Caduceus trial, approaching with late gadolinium enhancement and assessing the differences in LGE before and after, and making the extrapolation that whatever you reduce, it's probably grams of myocardial mass. How do you approach that? Because your vision was a little bit different, and if you were to design a clinical trial, would you use LGE, would you use echo, which would be your surrogate endpoints right now?
It's a very, very good question. And actually at Paco Vilas' stem cell meeting in May in Madrid, there's going to be an entire session on that. What endpoints? And it's a very difficult area. I mean, what do we really want? We want to show that the drug will reduce death and heart failure. That's really what we want. And the BAMI trial is the only trial that may answer that, with 3,000 patients. My own concern about that trial and that approach is what we are finding now as we look at our current data, both at the Mayo Clinic and elsewhere. If you look at people with myocardial infarctions, and what are they dying of 5 and 10 years later? They're dying of non-cardiac deaths, 50% of them. So if you're going to do a trial like that to show that a stem cell reduces death and heart failure mortality, you may have to double the power of the trial because half the people will die of non-cardiac death. So that's the perfect endpoint, is death and heart failure. But it's expensive. You may have to add many more patients. These are very, very, it's a $9 million euro trial. That's nothing. Huh? I think it has to be much bigger than that. So you then go to the other end and you use surrogate endpoints, like ejection fraction, strain, a regional wall motion. Or, as you said, Marwan has used an MRI endpoint, which I think most people will think is the gold standard. The problem with that is there's a great deal of controversy about the interpretation of the MRI. What you see in his trial is a change in the dynamics of scar tissue, and there is less late gadolinium enhancement. And what you see is more muscle. Now, whether that is regenerative muscle or hypertrophy And whether the changes in late gadolinium enhancement are just due to changes in the leakage of the late gadolinium is uncertain. And so Marban interprets that as a very positive finding. But Dr. Murray, Chuck Murray from Washington, was quite critical and said, I don't think you've shown that. And in that caduceus trial, there was no change in ejection fraction. So it's complex when you use surrogate endpoints. And the problem is we have to use surrogate endpoints because these are trials of 40 and 50 patients. We just, other than the trial that I'm chairing the DSMB of, the TIVA trial and the BAMI trial, there are no other trials of 5 and 10 and 20,000 patients. And I think it's premature to do those trials of 20,000 patients. So for the moment, what would I choose? I would choose MRI endpoints, regional function, and I think it will be interesting to look at PET scanning and metabolism in these patients and see if see what results we get. And the third area where I think we could, which is a great experimental model, is the patients who go to VAD with a ventricular assist device, because we can then use each patient as their own control. We can put the cells in, and that device will come out either at autopsy or at transplantation. So we can actually look at what has happened to the cells and study them. But it's all surrogate endpoints. Not ideal, but it's the best we can do.
Is there any question from the audience? I just have one last question. So a take-home message. Do we continue doing basic research and stop and put on hold the clinical trials, or we do both, or we do clinical trials without a good rationale?
Well, you like to put your finger on the controversial topics, I've got to say. Yeah. There has been an editorial saying all clinical trials there should be a moratorium. My answer is we should continue to do both. Carefully constructed clinical trials and the basic research. But I think, and for everybody in the audience, this is a great chance to work with basic scientists. I am not a stem cell biologist, but I've learned a fair amount about it by working with our basic scientists like Andrei Terzik and others. And remember, the basic scientists don't know as much about myocardial infarction as we do. So I think it's a great time to collaborate, and we should do both. And I would not put a moratorium on the clinical trials at all. I think I would design them very carefully. I think it was President Roosevelt who said, you know, if something doesn't work, then try something else. And if that doesn't work, try something else. But by all means, do something. And I think we need to really go at this for another 10 years and then make a decision about whether we go forward from there.
Thank you very much.
So thank you very much, Dr. Gersh. So it's my pleasure, my privilege to introduce Dr. Javier Escanet. Javier Escanet is interventional cardiologist. He's from Vigo, my current city, and he was the first person who led me in the past to feel in my hands a coronary guide wire. So that's the reason why nowadays I am not an interventional cardiologist, maybe. So he's really an expert in the field of coronary physiology, and in the topic he's giving us of the coronary physiology from macro to microvasculature for clinicians. Thank you very much, Javier, for being here.
Thank you very much, Mr. Chairman. It was a pleasure to let you handle the wire in that PCI. Thank you. So, well, first of all, please allow me to deliver my talk in English, because then it will be easier to correspond with our colleagues, our visiting colleagues. These are my conflicts of interest. My question, of course, this is a meeting on experts in ischemic heart disease, so we can go straight to the point. How ischemic heart disease became stenosis center? Why stenosis is considered by many, and particularly as the chairman was saying, by interventional cardiology, sometimes the absolute target of treatment. Well, there are a number of reasons that I have tried to outline here. I will be very happy to hear from you, but first of all, you may remember that angiography, in a way, was what you see is what you get technique at the time it was created. So it was consolidating from the very beginning the idea that the stenosis was central, This has, of course, maintained now with multi-line CT as well. We have the fact that this PCI accessible, so it explains that it becomes an easy target. And of course, the industry develops a lot of strategies to treat stenosis, and that explains why perhaps there are many more opportunities to have devices to treat stenosis than to treat, for example, the microcirculation. Well, the results are immediate. As soon as you put a stent, you have the proof that the whole thing works, that the stenosis disappears. Remember that the social representation of heart disease is very important. Patients and physicians are not happy to have narrowings in the coronary arteries of their own or their patients. It's similar to what happens now with bioresorbable scaffolds. Patients love to have a stent that will disappear, and that is something that affects our way of thinking heart disease as a dysfunction, as a sort of repair, something that has to be repaired in the same way that you do with the engine of your car. And finally, even functional techniques like FFR, I will try to demonstrate this, are stenosis-centered. So, again, as experts or physicians interested in ischemic heart disease, we are all aware that we have to review the whole concept of ischemic heart disease as something that is the consequence of obstructive and non-obstructive causes. You may have different domains in the coronary circulation, even in the heart itself, including the myocardial domain, and you may remember that the systemic disease, the cardiovascular risk factors, reperfusion, hemodynamic conditions will affect not only vessel domains, but also the myocyte itself. And this is extremely important to remember. So the objectives of my presentation basically will be in the first place to revisit the structure of physiology of the microcirculatory domain, because my experience is that we need to really think on this many times to understand what we are talking about. For this, I would like to come to the research of a good friend and a great physiologist, Joseph Span from Amsterdam, where he performed this multi-slice CT. It is a true multi-slice CT because this is a heart that has been filled with a fluorescent filling and sliced at the slices of a few microns. And at every slice, the heart is frozen. At every slice, there is a camera that is taking a picture of this slide and stored in the computer. So later on, you can make a full reconstruction of the heart. And this is basically the heart that was sliced in thousands of different slides that you will see now. And from that, it will be possible to make a very accurate reconstruction of what the coronary circulation looks like. So, starting from the epicardial level, this is the type of vessels that you will be attending. You will see then the perforator vessels, the Estes 1, Estes 2 type of vessels. Then you will come to the arterial level, and eventually it will not be possible to see here the capillaries, of course. And then you will start having the venous system at the other end of the coronary circulation. What is important to remember from this is that we may think that the coronary circulation is therefore a sort of network of pipes, but that is very misleading. Let's have a close look to the structure of the coronary microcirculation. So in the first place, we have different type of arterioles that are responding to different type of metabolic stimuli or stimuli in general. As a matter of fact, are the very terminal arterioles that are reacting to the presence of metabolic stimuli derived from energetic metabolism. And actually the flow that will be initiated by these metabolic stimuli in these small arterioles will trigger the dilatation of larger arterioles in which dilatation is endothelial flow mediated. So this is very important to remember because this is actually the place where endothelial dysfunction affects myocardial flow. It is not a sort of a spasm of the epicardial vessels. It is the fact that when somebody has endothelial dysfunction and the vessels, the terminal arterioles dilate in response to myocardial demands of blood, these vessels constrict. And this is where the problem, the patient that has coronary stenosis has a double problem. Has a limitation in the conductance of the epicardial vessel and has a paradoxical constriction of these arterioles that induce even more ischemia. But then we come to a second type of elements in the coronary circulation. Those are the venules and, more importantly, the capillaries. And the most important aspect of these elements is that they are sensitive to compression. So we will come to that in a second. So let's then make a sort of resistive model of the coronary circulation. Let's think of the resistance that is implicit in the epicardial vessels. If there is one stenosis, of course, it will be higher. Let's think in the resistance of these larger and smaller arterioles, the resistance associated to the capillary vessels, and then let's think in the zero flow pressure or central venous pressure. We will come after that. What I would like to think, to invite you, is to think of coronary circulation as a combination of cañerías or pipes, that is this part of the microcirculation, because as we will see later on, we cannot call this other aspect of the microcirculation any longer a network of pipes. So pipes have specific problems, of course. The one is that they get rusty, they get occluded. If we continue thinking in this type of analogy, that is what you will be finding in the coronary microcirculation when you have a structural remodeling of the microcirculation. This is a study that we performed some years ago. It was published in 2009 in Circulation, where we actually validated some physiological techniques comparing the results with the actual finding in the endomyocardial biopsies. And what you can see here beautifully is arteriolar obliteration in this patient that has cardiac allograft, and at the same time, something that was very striking at that time, a huge decrease in capillary density, what is called capillary rarefaction, that at that time was not reported yet in the context of cardiac allograft vasculopathy. So, as you can see, the coronary microcirculation undergoes remodeling, and this remodeling, again, has multiple origins. We have to think, first of all, in different dimensions of the process. We have to think in the signals that initiate this. We have, of course, the wall shear stress, that it is sensed by the glycocalyx and transmitted to the smooth muscle cells in the media. We have to think on the metabolic effect directly on the smooth muscle cells, also the pressure and the circumferential stress, and also factors, hemodynamic, hemorrhagic factors like conduction or convection. Then we have to think in different responses. You may have inward or outward remodeling of the vessels. You may have eutrophic, hypotrophic, or hypertrophic remodeling of the vessel. You may have many changes in the microcirculation. And on the top of that, you will have multiple interactions of this phenomenon. So that will imply that, for example, in patients in whom you have hypertension, you will have to have more inward hypertrophic remodeling of the vessels, while in patients who have, for example, perhaps dilated cardiomyopathy, you have a different type of remodeling of these vessels. Now, how important is this, and how unaware are we of this phenomenon? This is an extremely interesting experiment that demonstrates that when you have a pig and you create an artificial stenosis, immediately you will start have this type of remodeling. Here what we have is an eutrophic inward remodeling of arterioles. You can see that the arterioles get obliterated without having an increase in size of the arteriole. And you can imagine then that, again, the patient that has an epicardial stenosis now has a twofold problem, has also a problem in the microcirculation, with the addition that the reactivity of these vessels is completely abnormal as well. Now, the other aspect that is interesting, and this is another study in which the changes in the microcirculation are assessed with coronary artery stenosis, but also with hypertension, is that the addition of risk factors increases the remodeling of the coronary microcirculation. And you can see here the degree of arteriolar obliteration when you have a coronary artery stenosis and hypertension is much higher than when you have one of them individually, but you have a continuous modification of your microcirculation. It gets even more complicated when you look to the phenomenon of vascular rarefaction, because in that cases, it seems that sometimes the fact of having hypertension is slightly protective regarding the overall process of rarefaction. So, in a way, what I wanted to make the point with this slide is that you have a complexity of phenomenon going in terms of remodeling at the level of the coronary microcirculation that is strongly linked to what happens in the epicardial vessel and also on systemic conditions, hemodynamic conditions like hypertension. Now, the other aspect of the microcirculation is what it cannot be longer called cañerías or pipes. We have to refer now to drilled myocardium, basically, or perforated myocardium, or microtunnels. Because remember that the capillaries are just a layer of endothelial cells surrounding a tunnel of myocardium. So I'm going to show you some experiments that were done in Rotterdam at the time I was there. This is a long time ago in the 90s. This is a patient that in whom we induce a long diastole, giving a large amount of adenosine in the coronary artery. The idea was to create a long diastole to assess pressure and flow. Now, what is interesting here is that, as you can see, the pressure and the flow goes down. We don't have the pressure here, just the flow. But the interesting thing is that the flow stops at a pressure of 50 millimeters of mercury. Why is that? Why did not stop at 0 millimeters of mercury? Why it stopped much earlier than that? Well, the reason for that is that, in general, what drives the flow in the coronary arteries is the difference in pressure between the aorta and the central venous pressure. But in reality, what happens is that being collapsible structures, as I mentioned before, when you have an enhanced or high or raised interstitial pressure in the muscle or any extravascular compressive force on these thin tunnels, they get obliterated. So what happens then is that if this zero flow pressure that we see here is higher than the central venous pressure, as it usually happens, then you will have a much reduced coronary blood flow in the coronary arteries, a lower, say, range of pressures to have the blood moving. Remember this slide next time that you are treating a patient who has a cardiac arrest. I mean, sometimes when we are bringing somebody out of a cardiac arrest and the patient is with 50 millimeters of mercury blood pressure, we have to keep in mind that although we have that pressure and we see the bouncing of the pressure waveforms, the blood is not going through the coronary circulation, particularly if the patient is in a situation like in acute coronary syndrome or in a myocardial infarction where you have a raised interstitial pressure. Now, obviously a very important technique in assessing microcirculation, it was the first time that it was possible to assess it non-invasively, was nuclear magnetic resonance imaging. Now, what is very interesting, and again speaks about the confusion that there is about the term, is that a particular pattern that was found in the context of acute coronary syndrome was attributed to microvascular obstruction, and it became from them synonymous of being microvascular plugging, microvascular obstruction. The idea was that perhaps, you see, the microcirculation will be completely plugged by platelets and thrombus coming from the culprit coronary artery. Now, what it has been very revealing is that actually this specific pattern that we have there, it does not correspond to such plugging, but actually to hemorrhage and destruction of the muscle at that particular level. As a matter of fact, when you look to what happens in the neighbor areas, what you will see is not plugging at all. You will see areas of debris, granulocytes, but what happens in this particular dark areas in the nuclear magnetic imaging is that you will have full destruction of the muscle and therefore full collapse of these microtunnels. So this has been extremely important change in the terminology arising from this interesting translational study. Going back to the idea of this Copernican revision of ischemic heart disease, of thinking of the whole domain, we can now move to the idea of to review new approaches that could lead us to assess better coronary circulation. And I'm going to share with you just a couple of slides. In the first place, what we have here is one of the ways that it has been used in many different approaches, invasive and non-invasive, the use of coronary flow reserve, in which we measure coronary flow in baseline situation, induce hyperemia with adenosine, as you can see here, and then we assess the percentual increase in flow. In this case is 4.1 times the baseline flow in hyperemia, and we take this as an indicator of the status of the microcirculation. As you can see here, there is no gradient through the stenosis, and here we have some indexes of hyperemic resistance of the microcirculation. Now, when coronary flow reserve was developed by Lance Gould, he obtained in dogs these beautiful models demonstrating how coronary flow reserve will decrease drastically as you will reach a certain level of severity with coronary stenosis inducing animals. Now, when this was translated to patients in the 80s, it was very puzzling to see that this beautiful correlation between percent diameter stenosis and coronary flow reserve was no longer there. Why is that? Well, probably the reason is because the experiments of Lance Gould were conducted in healthy dogs. This is the picture that you get in Google when you look for a healthy dog. It's a vegetarian dog. But basically what this is telling us is that in the patients, in real life, we have a lot of confusing or confounding factors that interfere a lot between the relationship between geometry and coronary flow reserve. And of course, many of these confounding factors have to do with this complex resistive pattern that involves both the epicardial vessel and the microcirculation. Now, one of the reasons because fractional flow reserve has been very successful is because, in a way, it looked in another direction in terms of facing this complexity. The good thing about coronary flow reserve is that gives you a beautiful number that expresses the impairment of myocardial blood supply using pressure drop as a surrogate. Now, this is of course extremely simple, but it can be even simpler. And as a matter of fact, our group, jointly with Imperial College of London, developed this index that is called instantaneous wave-free ratio. It has created a lot of waves in the literature, as you probably know. But basically, the idea is to move one more step in simplicity so we can assess coronary stenosis without the need of giving adenosine. So just to show you how it is done, this is in the first system that was installed in the world, in our place, the first online system. This is the time it takes to interrogate an stenosis and to know whether the stenosis is severe or not. You just need to cross with the guide wire and then wait for a couple of seconds, and then you know whether the stenosis is significant or not. But the limits of using pressure drop as a surrogate of flow impairment are very important. First of all, you will have all the hemorrhagical conditions that may be different in situations where you have focal stenosis, like this one here, or when you have diffuse coronary artery disease. But more importantly, remember that FFR explores a specific domain in the whole scheme that I showed you before of the coronary circulation, and actually it gets influenced by all these different factors. Now, the way that FFR approaches this is simply by thinking of this like a black box, not taking this in account. And that's the reason because I was saying before that in a way, FFR, being a physiological technique, has reinforced again the concept of stenosis-centered approach, because it's just giving us a solution about whether the stenosis has to be treated or not, but doesn't give us any information about whether the patient has any other problem. So what we have conducted over the last couple of years is a study using what we call multimodality physiological assessment that combines not only FFR but other indexes that explore the microcirculation. One of them is the use of coronary flow reserve based on thermodilution. Like when we do a cardiac output, you see here the thermodilution curves at baseline, and during hyperemia, the flow is much faster, so the temperature recovers earlier. And this gives you a very good estimate just of coronary flow reserve, just making saline injections in the cath lab. And because you have also the pressure, you can combine this mean transit time with pressure to calculate an index of microcirculatory resistance. So you have two different indexes looking into the coronary circulation. Now, what we did is we plotted following a scheme that was developed by the group of Lance Gould, Niels Johnson. We plotted the measurements obtained with with fractional flow reserve about the stenosis against coronary flow reserve obtained with this technique. And on the top of that, we identified those that have high microcirculatory resistance. And by doing this, we found some very interesting findings. The first thing is that if you have any peace of mind when you are making an FFR and you see that the patient has an FFR of 0.85, if you have any peace of mind of saying, okay, we don't need to do anything, the patient is fine, forget about it. Because in 63% of these patients, you will have actually abnormal hemodynamics judged as either low coronary flow reserve or very high microcirculatory resistances. The interesting thing is that when you look to these different quadrants of distribution, you start finding some very interesting patterns. On the one hand, you will have what it is the congruent patterns between coronary flow reserve and FFR. This is obviously a situation where we all agree that there is a major problem in the coronary circulation and that caused by the stenosis and that should be treated. This is, on the contrary, the situation where you clearly do not need to do anything, because there are two techniques that are telling you independently that the stenosis is not severe. On the top of that, the coronary microcirculation, the resistance is normal. But in these subsets, you are finding something very interesting. Those are subsets that have, again, normal FFR, defined as more than 0.80, where you may have a major problem in the microcirculation, stated here as a low CFR and a high microcirculatory resistance, or concealed diffuse disease that is causing decreased CFR but normal microcirculatory resistances. So this is basically the same explanation that I have shown to you. Now, what is very interesting is that it's very difficult to get information on the prognostic value of this, but we have the luck of having in our team, joined since December last year, of a physician from the Netherlands, Tim van der Hoof. Their group had performed, more than 12 years ago, they had performed a large cohort of patients studied with Doppler guide wire and pressure, and where they had information on this large cohort of patients, 157 patients. So we have a long-term follow-up of these patients. And we have now looked into it. Tim took our approach, applied to this population, and the paper is coming now in Circulation Cardiovascular Interventions very soon. Here is the outcome in terms of major adverse cardiac events in the long term in the subgroups where you have discrepancy between CFR and FFR. And immediately you will recognize that this group has a tremendously high cardiac adverse events. Well, it turned to be that this is the subgroup where, despite having a normal FFR, the patient has a major problem in the coronary circulation or in other domains, either as a form of diffuse disease or as a form of pure microcirculatory disease. So this illustrates that perhaps in the future, and in a near future, we will be starting to change our way to approach patients that come to the cath lab with an stenosis, and at least to know that we can identify patients that are exposed at a higher risk of events in the future. We obviously need what we have to do in these patients is to focus in optimal medical treatment, in awareness that these patients have something that is very wrong in the coronary microcirculation, and try to improve the outcome in the long term. So remember, stenosis that may look very similar, that may have normal FFR, they may have very abnormal hemodynamics. Both of these stenosis had a very low coronary flow reserve, but on the top of that, this patient had a tremendously high myocardial resistance in this particular vessel. And we are getting this information for the first time. The impression is that we will be applying the different techniques that we have to different regions or domains of the coronary circulation. It is obviously out of the scope of this talk to talk about wave intensity analysis and other very promising techniques that can be used in the future, but the idea and the main message has been delivered. Now, soon we will have the fruits of a huge critical mass gathering. I mean, to me, it was a dream that eventually, after many years of trying to do this, two bodies of the ESC supported the idea of having an international summit on coronary microcirculation that was held in Madrid this year. There is a position paper coming from this. Here we have everybody, Bill Chillian, the father of the study of microcirculation and actually the chairman of the NHLBI registry that we had in the 70s, people, colleagues also from Dr. Bernard Gersh, Amir Lerman, and many other people working in the same area. So we are really excited about this. And finally, it goes without saying that all that I have shown you is due to the work of the team. There is only one missing person here, but we have it in the front lines, my colleague Borja Ibáñez, who was not this day in the cath lab. But these are the people that actually made possible to present you many of the work shown in this lecture. Thank you very much for that.
So thank you very much, Javier, for your exciting talk. So is any question from the audience, please? Yes, just one. Malcolm, please.
Javier, congratulations. That was an excellent talk, and I congratulate you on your very rigorous scientific approach to this. My question is maybe more practical question. It's not uncommon that we see discordance between FFR measured in the cath lab to non-invasive stress testing. And although FFR was originally validated against stress testing, in the real world we see some discordance, particularly with localization of ischemia. Could you address that, and do you feel that there's a particular type of stress test that is more suited for comparison with FFR?
Yeah, absolutely. I mean, remember that FFR is a great tool. It has demonstrated that it circumvents many of the limitations of angiography and that is very good for our patients. No doubt about that. And the first task we have to do is to really improve its adoption. Now, in terms of validation, remember that the whole validation of FFR comes from a series of 46 patients. And if you look to that New England Journal of Medicine, you will see that what it says patients were included if they presented a positive or negative test, any of the negative tests, and if after treatment they normalize the positive test, to make sure that they were studying stenosis that were the culprit of ischemia. Now, the question that was never made is, what happened with the patients who went out of the study because, despite treating the stenosis, kept having ischemia? These patients were never entered in the validation. And these patients are the patients that our research addresses and that our everyday practice addresses, the patient that has this problem. So I could show you beautiful cases about this, but typical example is we perform FFR, we send the patient to the ward because it's more than 0.80, and a couple of days later, our colleague from the ward comes and says, listen, this patient is not doing well. I have done an exercise test again and it's positive. So I think we need to treat the stenosis. And in these cases, typically, not always, is when we repeat this with multimodality physiological assessment, we find that there is something wrong, that coronary flow reserve is low, and then we reanalyze the whole thing, and we understand that probably the patient, you see, is still in the subacute phase of a subtle acute coronary syndrome, or that something wrong is in the coronary circulation. So unless you explore this, you will not find a solution to these discordances between clinical practice and FFR that you say is an extremely important point. Thank you.
So thank you very much, Javier. So we have some time constraints, but I have the opportunity to make only a very short question. So what's your opinion about the future of non-invasive techniques in the assessment of microvascular disease? What about myocardial contrast, echocardiography, or some expectations about CT scan?
Well, that's very interesting because in a way, and remember that I have insisted in the importance of adopting FFR, in a way the concept of FFR is so seducing. It is being used more and more as a sort of gold standard. As a reviewer of papers, I have many times to make the correction to authors of saying, well, FFR is currently the gold standard for detection of ischemia, and I have to say it is not a gold standard, it is not detecting ischemia. It detects stenosis that have been demonstrated to be linked with ischemia, but it's not. But it is so seducing that even non-invasive imaging is being challenged now, for example, by FFR-like indexes, like, for example, the one, the multi-line CT-derived FFR created by HeartFlow, which in a way is proposing that by making computational fluid dynamics based on multi-line CT, you can actually challenge techniques that have a much more direct assessment of ischemia based on, for example, modifications of channel permeability in the cells. So it's very, very interesting what is happening. And again, as you are saying, multi-line CT derived FFR, for example, is not exploring microcirculation at all. It is actually making an assumption of how the microcirculation may be, but it's not assessing that. So I think that your point again is very important. We will need to find ways, non-invasively, to assess what happens in the microcirculation in these patients. It is more time-consuming. It has all the limitations we have, even the cultural limitations that led to the slow adoption of physiology in the cath lab. But sooner or later, we will have to face that this is the dark side of the moon. We are just seeing the epicardial vessels, and we have sooner or later to address the problem there.
So thank you very much, Javier. Thank you very much for both speakers, because their lectures have been very exciting and amazing. And thank you very much for the audience. And of course, sorry for the 10 minutes late. Thank you very much.